Hi Ninja Nerds, in this video we're going to talk about the hypoglossal nerve, or cranial nerve 12. So what we're going to talk about is we're going to talk about the origin of the nerve, so where the nerve originates, what is the nuclei actually centered within the brainstem. We're going to talk about the course of the nerve, so where is the actual nerve moving through, what holes, where is it actually going. And then we're going to talk about the structures that it supplies, the functions of those structures, and then we'll throw in a little bit of tidbits on clinical correlations. All right, so let's get started on the origin of the nerve. Where are you going to find the actual hypoglossal nerve nucleus? The hypoglossal nerve nucleus is actually located within the medulla. So if you look here, we're going to throw it right, actually it's going to be kind of right here along this region here, but we're going to take a better section of it. We're going to look at it a little bit better because it's actually within the posterior part of the medulla. But for right now, we're going to draw it right here, okay? So this is going to be the hypoglossal nucleus. So the hypoglossal nucleus is located within the medulla, but within the posterior aspect of the medulla. To get a better look at it, let's actually take a cross-section of this and look at it from the actual superior view. Okay, so if we make a cross-section of this, we're going to see a bunch of different structures. So this is the medulla. Obviously, you see a lot of cluttering here. I'm going to try to explain it, all the structures around here. So you see these red nuclei that are kind of located within the posterior part of the medulla? That is the hypoglossal nucleus. Okay, so these little red structures right there, this is the nucleus of cranial nerve 12, right? So that's the cranial nerve 12 nucleus. Cranial nerve 12 nucleus. So that's the hypoglossal nucleus. These structures on the side, these green nuclei here on the side, this is actually called the dorsal nucleus of vagus. Okay, so what's this one over here? Dorsal nucleus of vagus. These blue structures, just to give you an orientation, this is actually going to be the nucleus of tractus solitarius, nucleus of tractus solitarius. And then if you really would like to know, because I know you guys are eager to learn all of these different things, in the back here, this is actually going to be the nucleus gracilis, and over here would be the nucleus cuneatus, right? And we'll talk about these when we talk about the tracts, right, the ascending tracts. Now, in front of the hypoglossal nucleus, you're going to see these two little bumps right there. The little bumps right there, those black dots. That's an important structure because it's actually a vertical structure that connects the third, fourth, and sixth cranial nerves. Remember the oculomotor nerve, trochlear nerve, abducens nerve? It basically allows for coordination of those muscles. We'll talk about that when we talk about the vestibulo-ocular reflex. But this structure here, that little structure right there, is called the medial longitudinal fasciculus. Okay, so it's pretty cool. Basically, is important of being able to coordinate those eye movements between 3, 4, and 6. Then there's this other black structure right here next to it that's actually called the tectospinal nuclei, which is going to be, the tectospinal tract, actually, the tectospinal tract. And then here on the actual, these little brown structures right here, these brown structures here are actually a part of another tract, which you guys are going to be learning about soon, is called the medial lemniscus, which is an ascending pathway, right? Ascending pathway, primarily from the dorsal spinal thalamic tract. Then, over here, these blue structures here are actually going to be the olivary nuclear complex. Depending upon what level it's actually going to be on, it would determine whether it's a little bit more superior or inferior. But we're going to say that this is the actual olivary nuclear complex. Okay, and then these black structures here, which are consisting of the descending corticospinal pathways, where they actually decussate, this right here is going to be the pyramids. So these are the pyramids. Holy frick, I butchered that name right there, right? So that's the pyramids. Okay, and these again, pyramids are going to be where the descending corticospinal pathways are running through. And then just to get a little look here, this is going to be C1 region of the spinal cord, where the cervical, the actual structure is coming out of the cervical plexus, so the cervical spinal nerves, so the C1 nerve, C2 nerve, C3 nerve, C4 nerve, C5 nerve, right? And we can just keep going on, right? But again, that's where the cervical spinal nerves are going to come out. All right, now that we know exactly where it is located within the medulla, how can we describe it? It's within the posterior medulla, anterior to the nucleus gracilis, medial to the dorsal nucleus of vagus, and posterior to the medial longitudinal fasciculus. Beautiful. All right, now, where is it going to move? That's important. It's going to move. As it moves anterior, there's another structure here. I'm just going to put it like this. It's actually called the reticular formation. We'll talk about that eventually too. But it moves through the reticular formation, through the medial longitudinal fasciculus, through the medial lemniscus, through the olivary nuclear complex, and out between the little sulcus here, between the pyramids and the olives, and then outwards. Ooh, that's pretty cool, right? All right, so how does it move outwards? It moves outwards through the reticular formation within the medulla, through the medial longitudinal fasciculus, through the medial lemniscus, through the olivary nuclear complex, and out between this little sulcus between the pyramids and the olives. And I'll talk about why, because that's an important clinical correlation there. So just to recap it, reticular formation, medial longitudinal fasciculus, medial lemniscus, olivary nuclear complex, and out through that little sulcus right there and outwards. Sweet deal. Okay, now we know exactly where the origin of the nerve is. Now let's talk about the course of the nerve. We already kind of covered a little bit of it, right? We know that it runs through the reticular formation, the medial longitudinal fasciculus, the medial lemniscus, through the olivary nuclear complex, out of that area between that sulcus. Then where does it go? It goes out, it goes through the actual dura mater, and it goes out of the hole in the skull, a special structure here, and this structure here is called the hypoglossal canal. So what is this structure here called? It's called the hypoglossal canal. You know, this canal is actually located within a bone coming off the occipital bone. It's called the occipital condyles. It's actually located within that bone. So the hypoglossal canal, that's where it's actually going to run. It's going to run right out through that sucker there, okay? Then as it exits out, we're going to talk about some structures that it'll pass by. Okay, so we know it comes out of that, pierces through the dura mater, goes through the hypoglossal canal where the occipital condyles are, and then it moves outwards. Okay, where does it go from there? Let's come back over here so we can see it a little bit in a more simplistic view, right? So it comes out here, right? And then where does it go? Passes through what hole in the skull? It passes through the hypoglossal canal. As it passes through that hypoglossal canal, it comes outwards, right? And it's going to be surrounded by a lot of other nerves in this vicinity, which comes out of what hole is this? What hole is this right here, guys? This is the jugular foramen. And what nerves are running through here? Cranial nerve, 9, cranial nerve, 10, and cranial nerve, 11. These suckers running through here also. It's going to run nearby these nerves, okay? Then, what other structure is going to be here? You guys should already know this. We talked about this a couple times already. What is this artery right here? The internal carotid artery. It's going to run near that. What's going to be on the other side over here? The internal jugular vein. And if you're really being particular here, what is this sheath right here that these guys are kind of running in? It's called the carotid sheath, right? Mainly the vagus nerve and the accessory nerve, right? Now, it runs through this area, so it kind of runs in between these guys, right? Then, ooh, what else is over here? You know, here you're going to have let's say that you have here like this. Come and give this branch off over here. Here's another branch of the common carotid artery right here. So there's another branch of the common carotid artery. So let's we put it like this here. Right? So there's our common carotid artery. There's that little bifurcation point, right? Let's say that this is the external carotid artery, and this is the common carotid artery here. So the common carotid artery will split into the internal carotid artery and the external carotid artery. This nerve will run in between these two. So it'll kind of move in between these two. That's another clinical important point. So where does it move? It moves in between the internal jugular vein. Then it kind of moves in between the internal carotid and external carotid artery. Okay. There's some other bony structures around here. There's another bony structure here. This bony structure is called the styloid process. So there's another structure here called the styloid process. You know the styloid process is important, but you know there's other structures that it'll move by too. You know there's a lot of muscles nearby here. You'll have what's called like the digastric posterior belly. So you'll have the digastric posterior belly. You'll even have some other muscles over here. If you actually can think about it like this, you'll have the other digastric muscle like the digastric anterior belly. What other muscles would you have? Maybe you'll have the mylohyoid, so the mylohyoid. Maybe you'll have the geniohyoid nearby here too. What happens is this nerve will kind of run right in between. It'll run through that mylohyoid. So it'll actually kind of move right through the mylohyoid. Okay, so it'll kind of pierce through the mylohyoid. So far, comes out through the hypoglossal canal, moves in between the internal carotid artery and the internal jugular vein. Then it moves in between the internal carotid artery and external carotid artery, moves beneath the styloid process. It's going to run underneath the digastric posterior belly. That's the 5th step. 6th step, it'll kind of pierce through the mylohyoid. Okay. Then where is it going? It's going somewhere. It's going to go to a bunch of different muscles here. It's going to go to a lot of the muscles of the tongue. What muscles of the tongue? Okay. It will go and supply this muscle right here. Okay, this is not an anatomically perfect diagram, but it's good enough, okay? It's going to supply this muscles right here. We're going to call this the hyoglossus. It's going to supply the styloglossus. It's going to supply the genioglossus. And another muscle nearby called the chondroglossus. It's going to go and supply the intrinsic muscles of the tongue. So what kind of muscles are going to be here? Let's actually write down these muscles. Okay, we'll label this one 1. So we're going to say this is 1 muscle, 2 muscle, 3, and then there's another one in here a little bit deeper, 4th muscle, and we'll say here 5. Okay, so what is 1? It's going to supply the styloglossus. Okay, that's 1. What does the styloglossus do? The styloglossus actually elevates the tongue and helps to pull the tongue backwards. So it elevates the tongue and retracts the tongue. It's then going to also innervate the hyoglossus. Let's say that's 2. Hyoglossus. Hyoglossus is actually going to do depression of the tongue and retraction of the tongue. Okay, that's the hyoglossus. Then it's going to go to the 3rd one, which is going to be the genioglossus. The genioglossus helps to protract the tongue and retract the tongue, but it helps to retract it more at like the tip of the tongue. And it depresses the tongue. So it has 3 functions: protraction of the tongue, retraction of the tongue, and a little bit of depression of the tongue. But the retraction and depression is a little bit more towards the tip of the tongue. Okay? Then it's going to supply the chondroglossus. And the chondroglossus is just basically going to support the hyoglossus. So it supports the hyoglossus to do what? Primarily depress the tongue. So it's primarily functioning with the actual hyoglossus to depress the tongue. Then it supplies the intrinsic muscles of the tongue. The intrinsic muscles of the tongue. You guys want to know it? Yeah, you do. All right, so what are those muscles? So it can supply the transverse muscles of the tongue. So the transverse lingual muscles, the vertical lingual muscles, the superior and inferior longitudinal muscles of the tongue. Longitudinal muscles of tongue. Okay, so what is it supplying? It's supplying the transverse and the vertical lingual muscles. Okay, and it's supplying the superior and inferior longitudinal muscles of the tongue. What are the function of the intrinsic muscles of the tongue? They help you kind of change the shape of the tongue. So like me being able to do this. And I curl the tongue, that's actually one of the functions of these guys, okay? So the hypoglossal nerve is pretty important because it controls the tongue movement. Now you might be like, okay, movement of the tongue, not that big of a deal. Yes, it is, because it helps in the process of phonation, as well as some of the mastication processes too. So it's important for phonation. What is phonation? It's the production of speech, right? So this nerve is very important for what's called phonation. That's why whenever there's damage to this nerve, it can actually produce what's called spastic dysarthria, if it's really bad, where they have a hard time being able to articulate the words. So it plays a role in phonation, but primarily within the articulation of words. The articulation of words, right? That's the function of those muscles there that are innervated by the hypoglossal nerve. Now, what's really interesting about the hypoglossal nerve is that it receives branches from the cervical plexus. You know, the cervical plexus is actually kind of going mainly from C1 to C4. So if you guys remember, we said that you have what's called C1. And if you know, C1 is really interesting because why? Remember, it actually, if you watch the cervical plexus video, right, what happens to the C1? The C1 can do two things. It can give off two branches. One is it gives off a superior root of the ansa cervicalis, right? The other thing is it gives off a branch that moves with the hypoglossal nerve. And when it moves with the hypoglossal nerve, it goes out to innervate two muscles. One of them is right here, the geniohyoid. There's another muscle in close proximity to this guy. What's another muscle that it actually innervates here? Besides the genio, so let's say this is the geniohyoid. It also innervates another muscle that's connected to the thyroid cartilage. And this muscle, we're going to write this one in black here. Let's write these in black. So it supplies the geniohyoid and the thyrohyoid. Okay? So these are important also within the process of phonation. Thyrohyoid is actually going to play a role within what? Specifically pulling down the hyoid bone. So it helps to be able to pull that hyoid bone down. And then also the geniohyoid is also important, but he helps to be able to elevate the hyoid bone. So these are also important muscles that are coming from the cervical plexus, but they move kind of in like a together here within the hypoglossal nerve. Let's imagine I kind of show it like this. They kind of are moving together. So some of these C1 branches are kind of moving with the hypoglossal nerve. But then if you remember, the superior root of the ansa cervicalis combines with what? What was coming out of C2? Remember C2 was giving a branch over here? And then C3 was giving a branch over here. And when they were coming together, they were forming the inferior root of the ansa cervicalis. And then this was giving off branches. What was it giving off branches to? And it was important to remember them in order. It was giving off a branch to the omohyoid, particularly the superior belly. Then the sternothyroid. Then the sternohyoid. And the omohyoid, inferior belly. Okay? So it's just giving you kind of like a connection between the hypoglossal nerve and the cervical plexus. Sweet deal. Okay, unfortunately we have one more thing we have to talk about and then we'll hit the clinical correlations. Okay, let's say we come up here to the actual cerebral cortex. You know, within the cerebral cortex there's specific nuclei located within the precentral gyrus. And the precentral gyrus is important because it contains the nuclei of the primary motor cortex. So what are these nuclei? Where are they located? They're actually located within the lower lamina, lower layers of the precentral gyrus. And this is specifically a part of what's called the primary motor or somatomotor, you could say either one, cortex. And again, this is located within the precentral gyrus. But these nuclei are located a little bit lower in the actual precentral gyrus. Why is this important? Because these suckers here can give off axons. And these fibers here are called corticobulbar fibers. They're called corticobulbar fibers. Why are they called bulb? Because the medulla is actually going to also given the name like the bulb. Okay? So it has these fibers here that move towards the bulb, the medulla, where the hypoglossal nuclei is. Now here's what's interesting. It does this. Holy frick. It looks like it's bilateral, a bilateral supply. That it is, my friends. So again, what would happen over here? You smart individuals watching these videos, I know that you guys are very capable of understanding this, that's moving down here. And then doing what? Moving down, these corticobulbar fibers. And then as it moves down, what does it do? It gives off a contralateral fiber, and it gives off a ipsilateral fiber. That's really cool, right? So that's a really interesting thing, is that these fibers are going to have bilateral supply to the hypoglossal nucleus. But that's also kind of a bad thing. Why? Because if you develop a lesion in this nerve, these corticobulbar fibers coming from the right side of the primary motor cortex, then you'll lose some of the actual motor supply to the tongue on both the right side and a little bit of the left side. Okay, so it's not so much a good thing, it's just interesting, right? So it does have contralateral and ipsilateral fibers. The only one that's a little bit more ipsilateral, I'm just going to make a note, it actually primarily is receiving ipsilateral fibers, is the fibers that are going to the genioglossus. So the genioglossus is actually going to be primarily having ipsilateral fibers. The reason why I say that is because you can actually take the hypoglossal nucleus and kind of section it out. And each part of the hypoglossal nucleus consists of cell bodies that are going to go to each type of muscle. So for example, pretend that that part of the hypoglossal nucleus is going to go to the styloglossus. That part of it is going to go to the hyoglossus. That part of it is going to go to the genioglossus. That part of it's going to go to, you get the point, okay? But again, remember that it does have bilateral supply to both the hypoglossal nuclei, except for the genioglossus, that's primarily ipsilateral. Sweet deal, we've talked about it. Now let's go over what happens. So we've talked about the origin of the nerve, we know where we can find it, we know the course of it, we know what structures it supplies, we know the functions of those structures, and we even talked about what are these fibers one more time here. They're called the corticobulbar fibers. And remember that they're having bilateral supply except for ipsilateral supply to the genioglossus, part of the nucleus, of the hypoglossal nucleus, right? Clinical correlations. We're going to make this super simple. Let's say that you have right here, in some type of situation where you have an infarction here, or maybe even infarction of the closer up to the cerebral cortex. Maybe there was a blood vessel here that was infarcted. Maybe there was actually structures here that were infarcted. But these corticobulbar fibers, let's say that there's infarction of those. If you have an infarction of this part, the upper motor neurons, why is that probably the most worst thing possible? Because, like I told you, it's not only supplying the right side of the tongue, but it's also supplying some of the muscles of the left side of the tongue. So it has bilateral supply. If that is happening, if you have corticobulbar fiber or nuclear up here in the cortex, lesions, it is the most severe. The reason why is you might have complete dysfunction of the tongue. Complete dysfunction of the tongue. Okay? Also, remember I told you it could affect the actual phonation process. They might have what's called spastic dysarthria. Okay? Where they have a hard time being able to articulate the words. And they might even have atrophy of the tongue. They might even have some atrophy of the tongue. But here's what's really, really important. If you remember when we talked about the accessory nerve, it also had corticobulbar fibers. We didn't discuss it a lot in the glossopharyngeal nerve, but it also has some corticobulbar fibers. Cranial nerve 8, cranial nerve 9, cranial nerve 10, cranial nerve 11, and cranial nerve 12 are receiving corticobulbar fibers. If these fibers are damaged, not only would it affect the hypoglossal nerve, but it could also affect the accessory nerve, maybe the vagus nerve, maybe even the glossopharyngeal nerve. Okay, so not only would it could have caused this tongue dysfunction or spastic dysarthria or atrophy of the tongue, but it might even cause the other problems with the glossopharyngeal, the vagus, and the accessory. Okay, what if we have a lesion here? What if there's a lesion of the actual nucleus for whatever reason? So let's say that you have a nuclear lesion here. So some type of nuclear lesion. You know, there's many reasons why you could have a nuclear lesion. What if there is some type of tumor? So you have a tumor that develops in this area. So here's a tumor. Oh, there's another thing. I should actually mention this one because this is actually probably one of the main causes of maybe having damage to the nuclei. One of the main causes. You know there's an artery that comes up here called the anterior spinal artery? And the anterior spinal artery can actually move through here and it can give off some branches over here, okay? It can give off a lot of branches to the medial lemniscus. It can give off branches to the medial longitudinal fasciculus. It can give off some branches to the pyramids. And it can even give off branches to the hypoglossal nucleus. If by some situation, let's say that you develop an infarction of this anterior spinal artery, you know what this produces? Medial medullary syndrome. Now, we're not going to talk superiorly about this, but I want you to understand that what could actually be damaged as a result of this. Well, we said it supplies the pyramids. So the pyramids could be affected by this. We said it supplies the medial lemniscus. That could be affected by it. We said it supplies the hypoglossal nucleus. That could be affected. And sometimes it might even affect the medial longitudinal fasciculus. I'm sorry, fasciculus, not vesiculus. So again, what areas could be affected? You could affect the pyramids. Why is that a problem? Because if the anterior spinal artery affects this, you might lose contralateral function of the muscle. So you might develop contralateral hemiplasia. You might affect the medial lemniscus, so you might have contralateral loss of sensations and vibrations and proprioception, right? What if you damage the medial longitudinal fasciculus? That controls the movements of the eye, so you might develop some type of vertical nystagmus, right? What if it develops damage to the hypoglossal nucleus? You might even have atrophy of the tongue. You might have ooh, that's a good thing we should mention right here. This could produce, if there's nuclear lesions, this could produce atrophy of the tongue, or it gets smaller. And it could produce this really, really nasty thing called fasciculations of the tongue. Imagine here I have the tongue, okay? And you imagine like a bag of worms underneath the tongue. And it's elevated above the skin. Just imagine like a bag of worms under the skin. That's what fasciculations are. And it's really, really rough, right? So these actually can develop fasciculations. And they might even develop what's called a tongue deviation. But this is more common whenever there's peripheral damage of the hypoglossal nerve. But I'll talk about this when we talk about maybe the peripheral nerve damage. Okay? So again, what could cause this nuclear lesions? Maybe a tumor, maybe some type of infarction or occlusion of the anterior spinal artery. It could even be due to multiple sclerosis, like demyelination of those axons, or even ALS. ALS can affect it too. All right, amyotrophic lateral sclerosis, right? Which usually damages the ventral gray horn, but it can actually damage the hypoglossal nucleus too. Okay, so let's say that happens with a nuclear lesion. Last one. Let's say that for some reason you develop like a lesion here at the base of the skull. So you know how it actually runs through here? Let's say that you develop like a metastatic lesion at the base of the skull. So some type of, like we said plenty of times, chordomas, choliostomas, maybe even a meningioma, some type of breast cancer that spread there, bronchial cancer that spread there, lymphomas that spread there. That could also affect the hypoglossal nerve. Another thing, this runs right near the internal carotid artery, right? So since it runs right next to the internal carotid artery, what happens if there is a aneurysm of the internal carotid artery? That could compress it. What if there's a vascular entrapment between the internal carotid artery and the external carotid artery? What if there is a paraganglioma? You know there's a paragangliomas here, which is the carotid body tumors. What if that's actually occurring there? So it could be many reasons. It could be due to a metastatic skull lesion at the base of the skull. It could be due to an internal carotid artery aneurysm. It could be due to a paraganglioma, like a carotid body tumor. It could be due to an entrapment between the external carotid artery and internal carotid artery. It could be many different things, right? But again, what happens if there's a lesion at this level, the peripheral nerve lesion? So you actually have the nerve lesion, so the actual peripheral part of it, not the nucleus, the nerve. Holy frick, let's erase that. So what happens if maybe there's some type of peripheral nerve lesion? Again, they could develop atrophy of the tongue. They could develop even worse fasciculation. What do I mean? The fasciculations can actually go deeper. They can furrow. So it can develop even worse fasciculations. And it could develop this thing called that tongue deviation. Now I'm going to explain this. And again, this is more common whenever there's the peripheral nerve damage of it. Okay, so let's say that a doctor says, okay, I want to test our hypoglossal nerve and I want to see if it's functioning. And they find that, let's just say our right hypoglossal nerve is damaged. If the right hypoglossal nerve is damaged, let's just say that. It's more common again with the nerve part, not the nuclei. But if the right hypoglossal nerve is damaged, when that innervates the right side of the tongue, the muscles on the right side of the tongue are not going to be able to function. So let's say that they have them protrude the tongue. If they ask them to protrude the tongue, you know what's going to happen? The muscles on the left side of the tongue are going to overpower the weak or incompetent muscles on the right side. So when you ask them to move their tongue and protrude it out, it's going to go to this side. It's going to deviate to the side of the lesion. So if the right nerve is damaged, it's going to deviate to the right side when you ask them to protrude the tongue. All right? So that's an important thing too. All right, Ninja Nerds, in this video we covered the hypoglossal nerve. I hope it all made sense. I hope you guys really did enjoy it. If you guys did, please hit that like button, comment down in the comment section, and please subscribe. All right, Ninja Nerds, as always, until next time.